hear me? Who keeps calling me? Is that better? A little bit. Now? I'm almost at the top. How about now? You can't hear me. That's as loud as it'll go. Check, check. Is that better? Can you hear?
We should use this as a backup.
Would you rather have that, Dr. Steve?
I don't know. I don't know if that's loud enough and...
I don't think it is.
Well, you need just a backup on this.
You'd have to, that's not very loud.
No, it's not.
You'd have to stand right on top of it.
Or we can use this as a backup, I guess.
Let me check something down here real quick. I'll tell you what.
Can you hear it?
I heard that. Talking to you.
Hello. Just,
Why did it cut off? Did it cut off?
Yeah, I can hear that. Yeah. All right. I'll get somebody on it as soon as I get everybody introduced. Good morning, everybody.
There you go.
That was sad. Good morning. Much better. Welcome to the 5th annual Catch the Wave Respiratory Care Seminar. We're having a little technical difficulty. I'm going to have to sit here and talk into this like this for just a moment. And I've already started messing things up. A few housekeeping things. First of all, if you look on the back of your program, we'd like to say thank you to all of our sponsors. They're out in the vending exhibit area. You'll have a chance to visit them between 10 and 11 with a break after that. Just a quick reminder, if you have cell phones or pagers, be sure to put them on vibrate or silence. And for the pediatric breakouts, that's going to be in room 153. If you go down this hallway right outside the door, the classroom is the first one on the left. That is also our overflow room. We are streaming live to there. And for you guys in 153, if you cannot hear me, please have somebody walk over to the main auditorium so that we will know. And the way it works, if you have questions for the presenters from the overflow room, please walk over to the auditorium. We'll give you a few moments to get here, and that way you'll be able to ask your question of the presenter or interact to make sure that you get your face-to-face CEUs. Pete's breakout will be in there starting after our first presentation here, our keynote. And for lunch, the overflow room is 153. All the afternoon sessions will take place here in the main auditorium. Thank you very much. It's like all of them are like, the volume's really down.
Even on the handheld one.
Yeah, I mean, try it.
Test 1, 2. 2, test.
better.
1, 2.
That's good. Okay, better? Okay, I didn't sound as loud as she did. Okay, all right, thank you, ladies. Just for this afternoon, lunches are going to be on the tables in the atrium. And you can eat in the atrium, outside, classroom 153. I know there's a nice picnic area outside of the building here if you go out this southern exit. And if you have any issues with comfort, please let one of the seminar members know, and we'll try to make everything, adjust the air or whatever needs to take place, happen to make you more comfortable. Did you have something?
No, I was just saying that 155 is the other room.
No, we don't have 155, I don't think. Yeah, okay. All right, it's with great pleasure that I get to introduce our keynote speaker for this morning, Dr. Alexander C. He's the director of the Intermediate Care Unit at Wake Forest Baptist Medical Center, our Winston-Salem campus. Do we have anybody from any other of our campuses here with us this morning? We have Wilkes represented. Anybody from Lexington? There's Lexington. Anybody from Davie? Brenners. Yay. All right. Strong showing for Brenners. All right. Dr. C is going to talk to us about the non-invasive ventilation in the acute hospital setting. Please welcome Dr. Alexander C.
Try to see if this will work.
All right.
Can you guys hear me well with this? Or should I use the handheld one? Okay, that. So you want the handheld one? This works fine.
Don't worry about it. I'll get it.
All right, good morning. You hear me now? Feel like the Verizon guy or the Sprint guy now. Well, thank you very much for inviting me here. And they asked me if I can come and give a lecture or a talk. I didn't think that they would put me first in the plenary. If I'd known, I should have dressed up more properly, I guess. Sorry, I had to go back to the unit after this. So. All right. So good. This morning, I'm gonna try to talk and clarify certain things about non-invasive use of the non-invasive ventilators in the acute setting. We'll review what the evidence we have for using them in what situations. I'll go briefly with some of the modes that you probably know more than I do, and I should probably be learning from you guys instead. And then we'll talk about some appropriate settings for certain situations. It will just be a general overview. I believe my partner and colleague, Dr. Naiman, is also going to give a talk tomorrow afternoon, I think, and he will go more into case scenarios and applications of non-invasive ventilation settings. So, in general, non-invasive ventilation is basically just ventilation without an ET tube. For all those who are old enough like me who have seen the negative pressure ventilations, we don't see them anymore as much as possible because of the disadvantages of those bulky machines and the advantage of a positive pressure ventilation. It's more convenient and more comfortable, and usually use a mask or a mouthpiece. I don't think a lot of people are aware that there is actually some companies that make just a mouthpiece without strapping a mask on the face. It's the Fisher-Paykel Oracle, which we usually use for patients who are paralyzed and who cannot pull out straps and stuff like that. Oh, I'm in trouble.
Okay, I got it.
Hello? Now?
Yes, that's what I just found.
Hello. Test.
Okay, will do. Thank you. Bye.
Okay. Good? Or do you want me to still use this? You good? All right. So some of the more common situations that we use the non-invasive ventilators will be acute respiratory failure, which is what we see commonly in the acute setting, COPD exacerbation, patients with heart failure exacerbation, airway compromise post-extubation. Some we've started using some in asthma, but we'll talk about what the evidence and supporting or not supporting that. Community-acquired pneumonia, and also sometimes in situations of palliative care. But that's also quite controversial. For chronic use, okay. For those probably more in the PEDS realm, or sometimes you see more of the neuromuscular disorders, some chronic hypoventilation like obesity hypoventilation, and some restrictive lung problems with kyphoscoliosis, and of course obstructive sleep apnea, without which we don't probably have most of these machines right now where they are, because they were primarily developed for obstructive sleep apnea, and really then we took that from the home outpatient setting to use in the inpatient setting, and now we're crossing the realm between patients who are on the outpatient with OSA, and then how do we treat them in the acute setting also. And Dr. Naiman will talk more about that also. So in some literature, there's, depending on where you look at, the failure rates of non-invasive ventilation can range between 25 to 40%. And it's very critical to pick the right patient off the start to know, to be more successful. So that's what we're going to talk about, the different case scenarios where we think non-invasive ventilation is appropriate and you'll be more successful, rather than delaying patient care, appropriate patient care, by trying non-invasive ventilation instead of going directly to invasive or endotracheal ventilation. In most cases, guidelines would suggest that you have to have adequate monitoring in a close step-down unit at the very least, or in the ICU. In Wake Forest, we pretty much have our guidelines to say that unless the patient is a no escalation, wherein you're just using the non-invasive ventilation for, let's say, routine OSA, or let's say the rare cases where the patient do not want to be intubated or anything, then we usually put them in a setting where we are ready to intervene and escalate if needed. So that's usually our step-down unit or our ICU units. Most data so far show that primarily in acute setting where the patient is really dyspneic, the full face mask is probably preferential over the nasal mask. And we'll talk about some other mask interfaces that in Europe is actually quite the preferred one, which is what we call the helmet mask, but it's not available unfortunately here. So again, it's very important not to delay the appropriate care if the non-invasive ventilation is not working. First, no. So contraindications for non-invasive ventilators, pretty much it's pretty self-explanatory. Patients are respiratory arrests, no spontaneous respiration, should not be placed on any non-invasive ventilators. Patients who are unstable, be it from shock, ischemia, MI, or any arrhythmias. Patients who cannot protect their airways. Patients who are at risk for vomiting and aspiration should definitely not be placed on non-invasive ventilation. Same way with their secretions. Agitated and uncooperative, this is controversial. Even at Wake, we had just had that meeting a few weeks ago talking about whether patients who are on a BiPAP and confused initially for hypercapnia, should we be allowing our staff to be restraining them? I'm more of the feeling that no, we should not be restraining them, but there is some more recent publication using of medical restraint, not physical restraint, but a little bit of sedation to help the patient tolerate the non-invasive ventilators. So I think in which case, if we can use a little bit of sedation, then this contraindication will be basically relative, and especially in a setting where you can watch the patient closely, you might be able to get away with trying the non-invasive ventilation initially and see if their agitation or delirium will improve with if their hypercapnia improves. And obviously patients with facial trauma and burns that you cannot put the mask appropriately, then they should not be placed on non-invasive ventilators. So we talk about negative pressure ventilation for those who were not aware or were born before this were phased out, or born after these things were phased out. So it's basically using a negative pressure. Basically, you're like attaching a vacuum cleaner to your chest wall so you can suck air in. Instead of pushing air, you're sucking air in. So the disadvantage of that, or the advantage is you don't have anything in your face, and patients are able to communicate. So there was it a couple of years ago that in the internet or U.S. news, they show this patient on the iron lung who just, who lived on that iron lung for 20-some years, actually 40-some years. So, but I don't think it is commonly used nowadays because it has the disadvantage of, as our population grows bigger and there's a concomitant upper airway obstruction and obstructive sleep apnea, it actually, putting negative pressure in your chest actually worsens your upper airway obstruction. So positive pressure is more advantageous. So these are the examples of, those who are Wake Forest probably know this picture on the left side. This is still in one of our buildings downstairs in the museum there. One of the first iron lungs used for the polio syndrome. On the right side is the more modern version, but I think that's only available in a European. I believe this is an Italian machine. Some of us have seen the cuirassed or the ponchos. Again, we pretty much phase out these machines nowadays. So positive pressure, as we say, it's delivered by a mask. For those of us who work in acute setting, or you may be more knowledgeable only of the nasal or the face mask, but actually in the outpatient, there's a lot more variations or mask interfaces that we can use. The most common one, the nasal mask, the face mask. We call this full face mask, but there's another one that's even fuller than this, which is the total face mask. I've never seen a patient ask for this yet, so maybe it's also good for the skin if you get, some hyperbaric treatment for your face and helps the wrinkles. Nasal pillows, we don't use this usually in the acute setting, and some people who are more claustrophobic but need or are more of the open mouth breathers may want to use the hybrid mask, which is a combination of the nasal pillow. Combination of this nasal pillow with some oral interface. And this is the helmet mask that is more commonly used in the European setting. And if you look at the more recent literature about non-invasive ventilation, acute respiratory failure, ARDS, they actually use this helmet mask. And obviously it's the people who publish those studies are biased for it, and they always say it's more comfortable, and you can, there's actually a port on the side that you can put in, like put an NG tube in. Those of us of you guys, you always get called by the nurses when the OG tube is on the side, and try to, where do you really put it? You put it up by the side here by the nose, by the side here by the mouth, on the side here, or the left side, the right side. And then you lose your seal in your mask. So supposedly with this one, it's more comfortable for them, and maybe it's just a matter of time before we see this in our settings. So why do we use the face mask for an acute setting? Primarily based on studies show that the patient in an acute setting where they're severely dyspneic, I think there tend to be mouth breathers. The face mask is better tolerated than the nasal mask, unless you have patients that have, with all the issues with claustrophobia, and then pretty much, unfortunately, unless you have the helmet mask, we're pretty much reduced to either we try to give them a little bit of sedation, or we have to go to interventional and intubate them. So the most comprehensive guidance I've seen actually came out a few years ago. This must be at least 3 or 4 or 5 years already. How many of you have seen this? Are from the Canadian? No Canadians in this room. It's not U.S., so it's not good, right? It's Canadian, or it's not it's European. Anyway, they gave a very good review and guidelines of specific recommendations for non-invasive ventilation, whether using bilevel versus CPAP, in what situations, and what the evidence is. But as this has been already at least 4 or 5 years old, we will talk about some of them that initially, when the guidelines that they would recommend, that now with more recent development and publications and evidence, we actually may change those recommendations. So in general, use of the non-invasive ventilation, we talk about the full face mask versus the nasal mask in the acute setting. They make no recommendations about which one is better, if it's just a CPAP, and no generalized recommendation whether CPAP is better than non-invasive ventilation or bilevel pressure. But we'll talk about certain situations where one may be adequate, one may not be, one is better than the other, or one is an overkill in certain situations. So you guys know this very well. There's the CPAP, there's the BiPAP, or actually we shouldn't be using word BiPAP. I hope there's no Respironics rep here, because we didn't ask permission. That's a registered mark, okay? So people just say BiPAP, but it's actually a registered trademark by Respironics, or I guess Philips now bought them. And it's actually their algorithm. So bilevel is the more generic term that we should be using, because there are other companies that have a bilevel mode and has a different algorithms. So as you know, CPAP is constant. Bilevel, you have an inspiratory and expiration. Depending on the mode, you can have a backup rate. With the newer machines now, they get fancier. It's almost like a Tesla auto driving. We don't need to set these things up. They're now the AVAPs, auto BiPAP, auto CPAP, and we'll talk about that, some of those different modes. So the auto CPAP is usually has a pressure sensor that will automatically increase the pressures as it senses. There's the different machines with different algorithms depending on the flow sense. Most auto CPAP available commercially at home, it goes only as high as 20 centimeters pressure. The BiPAP goes a lot higher. It goes up to 45 on the inspiratory pressure, and typically you set a delta pressure of between 3 to 8. So a nice number we usually pick is 4. So how about the auto positive pressures? So there's the volume assured pressure support, or AVAPs, and there's the IVAPs, depending on which company is making those machines. The difference is in the AVAP, it's volume assured. So you set a tidal volume pressure that you want the machine to try to achieve by increasing your pressure support. In the IVAPs, they use a minute ventilation. So the site, they take a 1 to 2 second sampling of minute ventilation and adjust based on the minute ventilation you want the patient to get. So there's a little bit, sometimes some people will say there's a little bit of delay of how the pressure goes up and down with the IVAPs compared to the AVAPs. Most of us probably in the wake system are more familiar with the AVAPs because of the V60 Philips that we use in the acute settings. The IVAPs or the ASB are usually mostly the other company, the ResMed, which is usually most used in the home setting in the more on the OSA and obesity hypoventilation population. So in the volume assured pressure support, you will need to set the minimum EPAP, the minimum IPAP, which is usually we set the gradient of 4, and then if you want a backup rate, if your patient is some component of central. In most recommendations, if it's an acute hypercapnic respiratory failure, you do want to give a backup rate, because some of them will be so because of their hypercapnia, they're so hypoventilating that if you give them adequate oxygenation, they lose that oxygenation drive, then they'll be even more hypopnic or they'll stop breathing. So you want to give a backup rate initially. And we see that a lot in the people we do sleep studies on. How many people work in the sleep lab here? So we have a what we call emergence apnea. So in patients who are who have OSA for years and they're so used to being so hypoxic, when we put them in the sleep lab and we slap a CPAP on them and we get rid of their hypoxia, we see a lot of central apneas after that, because it takes their brain so used to not breathing. Now I'm breathing for them and give them oxygen, they'll stop breathing. But most of these patients, you don't really need to give them a backup rate, because as high as 60 to 80% of them, after 2 or 3 months use of the CPAP, those central apneas disappear. So same way in the acute setting, when the patient comes in and they're so chronically deprived and hypoxic, once you start breathing for them, the brain will tell them, oh, I can relax now, I don't have to breathe anymore. So it's good to measure, to at least to give them a backup rate initially. So this slide I put in always just try to explain to explain to the students. It is very critical to understand why are we using the non-invasive ventilation. So if you have a patient who has a COPD exacerbation, who has the typical pink puffer, emphysematous cachectic patient, you probably don't need that much of a pressure to help the patient ventilate. But if you have a patient who also at the same time has an upper airway obstruction, like patients with OSA, simultaneous with the COPD, like our chronic bronchitis, our obesity hypoventilation, with who also smoke, who also have COPD, you have to understand that you need to increase that expiratory pressure also to overcome that upper airway obstruction. So sometimes we'll see patients set up on 15 or 20 over 5, and their neck is like 20 inches, and we're saying, oh, how come the CO2 is not dropping? Because, yeah, you're pushing air in, but you're not giving them enough expiratory pressure to keep their airway open, which is in this slide where you have a fixed, what is it showing? Where you have a fixed upper airway obstruction that you have to overcome that critical pressure to keep that airway open. So again, if we think there's an upper airway obstruction, As long as we maintain that gradient of 4 between I and E, we need to increase that E until we can get that. The nice thing with the AVAPs, I can see what volume I'm getting as I increase the EPAP and the IPAP together. And that's how we actually titrate the BiPAP machines in the sleep lab, and that's how we can apply for those people who cross over between sleep lab and the acute settings. They're so used to titrating the bi-level pressures as more than some of us. So, clinical applications, what are the cases wherein we use the non-invasive ventilators? Heart failure, patients with hypercapnia and pulmonary edema. The main benefit of non-invasive ventilation and heart failure is try to improve gas exchange by improving VQ mismatch. For those people that have been, let's say, who typically come to our hospital after 2, 3, 4, 5 days of being short of breath, it does give them a reprieve and give them some respiratory muscle rest. There is data to show that positive pressure in acute setting of heart failure and pulmonary edema in systolic heart failure, that they actually improve cardiac stroke volume, so that's also helpful. In the long-term patients with change strokes, we've actually, those who are familiar with the HF-CERB publication that came out 2 years ago, we actually found out what we thought with ASV giving them backup rate for the change strokes, we thought would help them, but actually not. So it's actually now contraindicated to give them ASV on patients for change strokes because they actually have higher mortality. So in this article published in the New England Journal, basically they've shown that in patients who have heart failure alone, CPAP versus non-invasive ventilation, there's actually no difference between bi-level versus continued CPAP levels. CPAP has positive advantages over oxygen alone, but basically you don't really need bi-level settings in the patient setting with CHF. That's another thing, if you have CHF and systolic heart failure with upper airway obstruction, that you need higher pressures, then sometimes you may need the bi-level. But if you have the current models of the auto CPAPs, it's actually, some of them have a mode that you can actually, it's a cheap version, cheap man version of a bi-level because it has an expiratory release. So basically it gives you a higher inspiratory and a lower expiratory pressure. So in this publication in the chest, they actually studied patients who were admitted for acute heart failure, and they've shown that giving them the CPAP or non-invasive ventilation in the acute setting, they were able to actually demonstrate improvement in left ventricular ejection fraction. So there is some inotropic support with positive pressure ventilation. The way we explain that is it's twofold. With positive pressure ventilation, you decrease venous return and you unload the right side of the preload, right? Which is pretty much like we're diuresing the patients. At the same time, because your heart is big and boggy, it's inside your thoracic cage. If you put positive pressure in your lungs are actually pushing your heart a little bit to a better Starling, based on the Starling curve, in a better position where they can contract better. And it also gives an afterload reduction. So when we say afterload, we say is the heart has to contract from this diastolic size to this systolic size. By putting positive pressure at diastole, we're actually giving them much less to contract. So that's the afterload reduction that positive pressure actually helps with patients with systolic heart failure. Now this doesn't work in in what we now call the HFpEF, or heart failure with preserved ejection fraction, or the diastolic heart failure. That's totally, we don't know how those patients react to CPAP, and that's part of what some of us want to, learn more, and probably Dr. Naiman will give you more insight on that. So in cardiogenic pulmonary edema, the recommendation says that CPAP is probably adequate. You don't really need bi-level positive pressure. There's no recommendations versus non-invasive ventilation versus standard oxygenation in the acute respiratory failure and pulmonary edema, and we'll talk about that also later. I'll give you the more recent studies with the high flow oxygen data. As far as here in pneumonia, there's really no data to support it for now. There's actually some studies that we'll talk about later that actually they may be actually worse with pneumonia and use of non-invasive ventilation. So again, this is more of a generalized review and summary of all the data available for non-invasive ventilation for acute respiratory failure. Basically, there is data to show that yes, in a proper setting, in a proper selection of patients, that they can decrease hospital mortality, they can decrease your intubation rate, and generalized decrease in length of stay. In this also, they showed that, they said that so far there is data that if we don't intubate the patient, then, and they can survive or overcome the acute respiratory failure with non-invasive ventilation, then we reduce the incidence of community-acquired pneumonia, and that's where the recommendations come from, preferentially using non-invasive ventilation in immunocompromised neutropenic cancer patients, and we'll talk about that also later. Okay, so the more recent controversy and all the talk about in acute exacerbation COPD came from mostly the inpatient studies. In acute exacerbation COPD, non-invasive ventilation have shown that we've increased their reduce their mortality, decrease their hospital stay, and more recently now there's data to show that long-term use of patients of non-invasive ventilation in the home setting in patients with COPD may benefit them in reducing readmission. So again, we want to emphasize the proper selection of the right patient, and not just everybody who has COPD. And I say quote COPD, we have so many patients who come in the hospital with a carrying a diagnosis COPD, but never documented to have COPD, like there's no PFTs or anything. So, and then they get thrown into the same basket as COPD, and they're given the same non-invasive ventilation, and we don't know if we're doing them good or actually doing them more harm. So again, in this overall Cochrane review, most evidence favored that non-invasive ventilation in an acute setting in COPD exacerbation does reduce mortality, it reduces intubation rate, and reduces the length of stay, and also ICU length of stay. But it is important to note that, again, we'll talk about proper selection of patients, that the benefit of non-invasive ventilation is mostly in patients who actually have respiratory acidosis or pH of less than 7.3. So if it's more than 7.3, as the, for those who are familiar with the high flow oxygen data, show that if you don't have hypercapnia, high flow oxygen is actually just as good as putting them on non-invasive ventilation. So in patients with COPD exacerbation, talk about this: reduction in intubation rate, reduction in mortality, reduction in overall ICU and hospital stay. And again, we have to make sure that we proper selection of the right patient that will actually benefit from this. So this is the same summary. So they said what I want to bring with us is, here it says about use of Heliox. They have no recommendations. That was 4 or 5 years ago. There's actually a more recent publication that actually talked about Heliox. And that was published in the, I think this is the Annals of Thoracic Surgery. So they enrolled 445 patients with continuous use of Heliox. Although the Heliox improved their physiologic parameters, the drop in CO2 was faster, they decreased their work of breathing, pH corrected faster, respiratory rate improved. However, there is overall no reduction or no effect on non-invasive failure rate or ICU hospital stay. So, and with Heliox being so expensive, the current recommendations do not recommend using Heliox in acute exacerbation for COPD patients. This is the high flow oxygen study that came out in 2015. So again, this says acute hypoxemic respiratory failure. Note that in this study, the patients, there are no difference in the two groups as far as their pH is concerned. They're mostly normal pH. They don't have respiratory acidosis. Therefore, they showed that non-invasive ventilation did not do any better than just high flow oxygen and correcting their hypoxemia. And in fact, in those patients who have more severe hypoxemia, high flow oxygen is actually better than non-invasive ventilation. In the same way with survival, overall survival, they do better with high flow oxygen. So these are only purely hypoxemic patients. So again, we cannot overemphasize the selection of the right patients in the right setting. How about in the patients with asthma exacerbation? With this Canadian society, at that point they had no evidence to recommend one way or the other. More recently, in 2016, this publication showed that actually in those patients, unfortunately this is just a retrospective study, it's not a prospective study. There's no really data to support asthma, the advantage of non-invasive ventilation in asthma or not. And patients who have asthma exacerbation and actually had simultaneous pneumonia actually did worse with non-invasive ventilation. So if you have patients with asthma exacerbation with lung infiltrates and you're treating for pneumonia, that's probably, if they become hypercapnic and they're not tolerate and not just pure hypoxic, then probably non-invasive ventilation is probably not something that you will want to go through, and we just have to go straight to intubating these patients and doing interventional ventilation. Chest trauma, again, there's no standard recommendations. Now at this time, during that time, they did say that there is some evidence to show that in patients with immunosuppressed, that non-invasive ventilation has an advantage of giving them a trial because it reduces their hospital-acquired pneumonia. How about using non-invasive ventilation patients with post-extubation? Again, the data does show that in patients that you expect with hypoventilation and hypercapnia, or patients that have upper airway obstruction or OSA, there is an advantage to extubating them directly to non-invasive ventilation. Upper airway obstruction include not just OSA, but also if you anticipate some degree of post-extubation stridor, because positive pressure will also help the obstruction from your laryngeal edema. Actually, it's more in the anesthesia literature that using post-extubation CPAP to keep your airway open is actually more effective than throwing them racemic epinephrine and all that stuff that we throw at them. Again, So this, in summary, basically in the patients that you anticipate that there's airway obstruction or hypoventilation, then non-invasive ventilation should be recommended after extubation. So this is again just a summary of what we just talked about in post-extubation. If you do not have COPD, you probably should not, or you don't anticipate hypercapnia or airway obstruction, we do not routinely recommend positive pressure ventilation after extubation. So these are the more recent studies shown in immunosuppressed or cancer patients. Basically in a retrospective patients, if patients who are placed on non-invasive ventilation and fail, that is an independent risk factor in itself for mortality. So so it's still recommended that we should probably try them on non-invasive ventilation, but it is also prudent to know when to intervene and not to intubate and not to intubate, because if we delay the care, non-invasive ventilation failure in itself is actually a worse prognosis. Unfortunately, this study did not provide any data to show whether using non-invasive first versus intubating first is their advantage over one or the other. It just says that if you try the non-invasive ventilation in the patients who are immunocompromised or neutropenic and they succeed, they do better. And that's all we can get from this study. In this article in Pulmonary Medicine, British Medical Journal in 2016, they did compile all the studies in the use of non-invasive ventilation in immunocompromised patients. Unfortunately, there's no randomized clinical trial studies, so those people, any of you are interested in doing some clinical research, these are some patients that we can probably look into. There's really no data to show one is better than the other. At the very least, they just say non-invasive ventilation trial. It does not harm the patient as long as you intervene in time if the patient is not responding to non-invasive ventilation. So, summary, what do we know for now? We have strong evidence that non-invasive ventilation is helpful in patients with CHF, systolic heart failure, and acute pulmonary edema. Number 2, acute exacerbation of COPD with hypercapnia. Okay, if it's just purely hypoxic, then there's really no advantage. Selected patients post-extubation that we anticipate CO2 retention or upper airway obstruction. Patients with OSA, concomitant OSA. Not enough evidence. Pneumonia, actually in that one study, the asthma patients with pneumonia getting non-invasive ventilation and delaying intubation is actually more harmful. Same way with asthma, especially if they have a concomitant pneumonia. In immunosuppressed or neutropenic patients, again, proper selection of patients. It's worth trying non-invasive. If they do well with the non-invasive, that's better for them. If they don't, that's actually a worse prognosis. But predicting which patients will do better or not, unfortunately, we don't have enough data yet to be able to tell that. So again, I cannot overemphasize the importance of what are we treating with the non-invasive ventilation? What are we trying to overcome? Is it muscle fatigue with hypoventilation? Is there also airway obstruction? And that will then entail and dictate to us how we set those parameters in our non-invasive ventilators. And again, as I was joking with Dr. Naiman, I'm just the front act for his main act, which is he'll talk more about case presentations of specific non-invasive ventilation cases and then how you would appropriately set those patients up for success versus, with an NIV. Questions? I hope you learned something. Okay. You guys have a good day and enjoy your lectures.
Thank you, Doctor. Thank you.
Oh, I got a goodie bag.
Yeah, I'll get a bag for you.
Makeup kit?
Yes, makeup kits and lipstick and everything.
Those Oscar awards, they get all this makeup.
Exactly. You're welcome. All right, so we have 15 minutes till the next one starts. So we'll just say there's 10 minutes till the next session starts. The adult talk with Dr. O'Hara is going to be in this room. And Dr. Bass, Andorra Bass is going to be in 153. And that'll be the peds talk in there. So this will give us 10 to 15 minutes to switch for those who are going to the pediatric, and the rest of the adults will be